Good afternoon. I'll be taking a brief session on sulbactam and how this molecule can help in the treatment of multi-drug resistant or exchange drug resistant Acinetobacter infection. So this will be a very layman and very simple approach so that whenever our colleagues in the medical field and those who are being in the representative side can give an explanation and justification to the queries of the clinicians as well as some of the fellow clinicians and the juniors as well for them, like how this molecule is one of the options in the future. So coming down to the first, we'll be learning is what are sulbactam, what are the different beta-lactamase inhibitors, what is antimicrobial resistance, what is this Acinetobacter baumanii and why this carbapenem resistance we are facing, and what are the treatment options we are having currently right now, and what can be the other scopes and options. So coming down to the first, what is sulbactam? So it is nothing just as a beta-lactamase inhibitor. This drug is a combination with beta-lactam antibiotics to inhibit the beta-lactamase, an enzyme produced by a bacteria that destroys the antibiotic. So sulbactam is not a single molecule that can work just as its own. It has to be used in combination, which will inhibit the enzyme that is affecting the bacteria. So this molecule is not new. This is a very old molecule and it was patented in 1977 and approved for use by the US FDA in 1986. So this is nothing new. This molecule was also there in our line, but now we are getting a good results when we are using it with combinations that I'll be talking in the later slides. So what is beta-lactamases? This is basically a family of enzymes produced by gram-positive and gram-negative bacteria. We know that there is GNB and GPC. GNB means gram-negative bacteria and GPC are the gram-positive cocci. So what these beta-lactamases do, they inactivate the beta-lactam antibiotics by opening the beta-lactam ring. You think it as a ring, the ring opens, attaches to the bacteria, and the bacteria produces this, the antibiotics gets bound to it, and the antibiotics won't be working because of this beta-lactam ring and this beta-lactamases. So, and what do? They are the inhibitors of the beta-lactamases, resembles the beta-lactam antibiotics, and do not possesses any antimicrobial action. So this inhibitors, which we are talking about sulbactam, so this inhibit the beta-lactamases so that the antibiotic, the first choice of antibiotic that is given alongside this beta-lactamases works directly on the organism so that it can either have a bactericidal or a bacteriostatic effect. So how does it do? It binds irreversibly to the catalytic site of the susceptible beta-lactamases, particularly the penicillins, to prevent hydrolysis of the penicillins. So these are also termed as suicide inhibitors because it will go directly bind to those sites and are ready to destroy the beta-lactamases so that the molecule, the antibiotic, can work and do its job over there. So currently we are dealing with 3 beta-lactamases inhibitors that are currently available and everyone has seen, like clavulanic acid, sulbactam, tazobactam. Clavulanic acid is widely used alongside with amoxicillin. It was in the brand name of Augmentin, which was the innovator molecule which has amoxicillin and clavulanic acid. It is available in IV form, oral form. This is very commonly used antibiotic. Tazobactam, on the other hand, is one of the most famous IV antibiotics, beta-lactamases inhibitors, alongside an antibiotic like piperacillin. So the piperacillin tazobactam, which is in the brand name of Zocin, Pipzo, Piptaz, everything we are having is quite well known and used for gram-negative bacteria. So tazobactam is also used alongside other cephalosporin group so that they can have a better approach on this bacteria and this beta-lactamase inhibitions. Coming to the other hand, sulbactam. Sulbactam is used alongside ampicillin or cephalosporin. So this is what we have seen over the period of time. But due to this multi-drug resistance, we are have to just use this beta-lactamase inhibitor in a separate and in a more potent role so that we can get over this resistance and bring a better one. So clavulanic acid I have told oral and parenteral, and sulbactam is also a semi-synthetic one. Tazobactam is an analog of sulbactam only, but this has been derived over the time and period. So these agents are given together with the hydrolyzable penicillins to protect them from inactivation. This has extended use of penicillin against beta-lactam producing bacteria. So there are many things you can see over here like clavulanic acid, amoxicillin, sulbactam, ampicillin, tazobactam, piperacillin. These are fixed dose combinations and are used widely. These are the usual doses which they are available. They are in multiple strengths. I don't want to get into it. You will be knowing it well enough because piperacillin tazobactam ranges from 2.25 gram to 4.5 gram depending on the requirement of the patient as per their body weight or renal adjustment or hepatic adjustment. So, which are the organisms they are mainly effective against? Is beta-lactamase produced by those staphylococci, the influenza, gonorrhea, salmonella, shigella, E. coli, and Klebsiella pneumoniae. The last two organisms, E. coli and Klebsiella, these are the very common and notorious organisms which are widely available in the hospitals, and these are multi-drug resistance nowadays. ESBL is also there, but we are having pan or multi-drug resistance E. coli and pneumonia, Klebsiella pneumonia. So these are the main organisms for the hospital acquired infections alongside with Acinetobacter and some other. But these are the main dominating ones: this Klebsiella, E. coli, and the Acineto ones. So what these beta-lactamase inhibitors are effective against this producing organism, like ampicillin in combination with sulbactam is effective against Pseudomonas aureus or Haemophilus influenza. So this is quite a bit outdated, but still this is the traditional and conventional method. And non-beta-lactamase producing microorganism, there is no advantage over the other antibiotics, and these are ineffective against MRSA, which is the methicillin-resistant Staph aureus. So we have limited scope and use for this combination of the beta-lactamase inhibitor class. So therapeutic use, sulbactam is used for odontogenic infections caused by beta-lactamase producing Staph aureus, E. coli, gonorrhea, salmonella. It is a mix of nosocomial infections, skin and soft tissue infection, urinary infection, respiratory, which is the VAP, and UTI, mixed intra-abdominal and pelvic infections, and HAI, as these are the leading causes. So there are various scopes, but these are the old traditional ones. I'll be going in deeper what is the future and what are the current guidelines saying for use of sulbactam. How this works, I think this is having a very vague and in detailed explanation. I'll just go in basics how it has been done. It is basically by the cell wall of the bacteria that has the normal growth and development, which has the peptidoglycan chain over there, and it goes and attaches to those chains and hydrolyzes that. So this provides a rigid mechanical stability to that. Okay. This is not recommended in endocarditis. I have just put it this slide just as a recommendation from the WHO. So what is the current scenario? So the relative or complete lack of effect of antibiotics against a previously susceptible microbe. We are dealing with this right now. Everyone is looking into multi-drug resistance organisms and pan resistance, supposedly Pseudomonas or even Klebsiella. We are having carbapenem resistance, even colistin resistant organisms, right? So how this resistance develop, we have to understand that in basic. So there are multiple ways of developing a resistance, which include enzymatic inhibition alteration of bacterial membranes, rapid ejection of drug or reduced drug influx, bypass of antibiotic inhibition, and alteration of target sites. So these are the various mechanisms how a resistance develop. Okay. Molecular genetics of antibiotic resistance includes this duplication, deletion, transportation. These are all in detail various ways. If anyone wants to know, I'll just explain it in the later slides. But this is a very complex picture. If you can see, this is the bacteria, how the antibiotic goes in, where is it is getting. If you see on the right hand side, the antibiotics are going in, they're getting degraded in an enzyme, and then efflux. Many mechanisms are associated, but at the end of the day, we are having resistant organism due to multiple failures. One may be inappropriate antibiotic, maybe the duration was wrong, maybe the dose was wrong, maybe the way and the method was wrong. Maybe we have given a broader spectrum antibiotic to treat an organism which was required for a narrow spectrum. So multiple factors are there which we are causing this resistance on. So enzymatic inhibition, as I have told, these are basically the split of the amide bonds and the beta-lactamase rings. These are in detail topics. If anyone wants to clarify what is this, I can just go in detail like how this enzymatic inhibition and inhibiting antibiotics work. But you can self-refer it as well. So the beta-lactamase is this what happens. So it hydrolyzes the oxacillin and related penicillins. So this production of the enzyme or the antibiotic, which are having this plasmids or the chromosomal genes, and the organisms supposedly, if I say aminoglycosides or chloramphenicol, are the traditional and the conventional method which were used for the treatment supposedly a complicated UTI or hospital-acquired infection like a VAP. So basically, this were having multiple complications. If we give an aminoglycoside or a chloramphenicol, this had multiple effects in the body, which has a common side effect of renal injury. So this was mainly not a choice earlier back then. Sulbactam, on the other hand, was effective to some extent, but it was only to be given with a combination. So cephalosporin sulbactam was there in the late 90s. Later on, ampicillin sulbactam we have also given, but due to resistance to ampicillin and cephalosporin, so that has been a challenge widely. So as you can see, most cephalosporins are inhibited by clavulanate, sulbactam or tazobactam. Carbapenems are metalloenzymes inhibited by EDTA but not clavulanate or sulbactam. So EDTA, this is also a very old molecule that we have been using as a chelating agent, but now there are various studies going on and trials going on for the use of sulbactam later on and EDTA as well in the supporting role. So this is how it is right now. So where does this beta-lactamase site of action? You can see in this ring, the penicillin is, this is the diagram of the penicillin is. So it acts on the beta-lactamase ring. So this is where the site of action is usually there. So modifying the enzymes is also a cause for this resistance, which includes N-acetylation, O-nucleotidation, or O-phosphorylation. So these are various methods that we are observing right now, like erythromycin is seen in E. coli hydrolyzed lactone ring, thus deactivating it limits utility of oral erythromycin in reducing the aerobic gram-negative flora of the GIT prior to the GI surgery. So erythromycin was widely used earlier back then in the GI surgeries, but nowadays, as we can see, if it's a clean surgery, then we usually go for cephalosporins, which is the second generation one. If it is a contaminated surgery, then we will have the clinical evaluation and go for a decided approach, which may include a higher antibiotic. So what are these enzymes? How does it look like? And how does it block? So in the first picture, you can see there are the enzymes that are binding to the antibiotics and essentially degrading it to make it inactive. later on developing a resistance. And in the second picture, you are seeing that blocking enzymes attached to the side chain to the antibiotics that inhibits its function. So this is how it gets blocked or degraded over the period of time and develops resistance on it. So alteration of bacterial membranes is another cause for this antimicrobial resistance. So outer membrane permeability and inner membrane permeability. This is the two aspects that we can see in this membrane. So there are various factors that is contributing to the, depending on the permeability. If the bacteria develops a thicker membrane and does not permeates the antibiotic inside, it won't be having the binding to the sites and won't be able to do its work. So there are two layers, which is the outer and the inner ones. Basically, they are having multiple changes to the cytoplasmic membrane and will be having this mutation throughout, and this is what we have been facing right now, why this is so much resistance in the microorganisms. And promotion of antibiotic efflux, major mechanism for tetracycline resistance gram-negative plasmid or chromosomal transpose mediated. So there are alterations in multiple levels that is basically the leading factors for this antimicrobial resistance. First of all, irrational use of antibiotics is also one of the major factors. We are nowadays adulterating every possible site, even use of antibiotics in the farming and in the animal poultry for getting better yields, but we are majorly causing destruction in our own. So bacterial cells have infinite capacity to restrict the entry of small molecules, especially gram-negative outer membrane, to protective gram-positives, no outer membrane, hence more antibiotic sensitivity. So this efflux and influx mechanism is the main cause which are contributing to this antibiotics efficacy. So the most well-studied efflux system in E. coli is the ACRB system. This is compromises of the inner membrane and the outer membrane of the protein, and the tool C is linked to the periplasmic protein ARC membrane. So when activated, the linker property protein is believed to fold on itself, bringing the ACRB and the TOLC proteins in close contact. So this is how the antibiotics is pumped out of the channel. This is what the influx means, getting in, and efflux means getting out. So this is how the influx and efflux process works. So you can see in the picture right now. So modification of the target size due to the changes in the ribosomal target size is the failure of the antibiotics for the attachment and are having more resistance nowadays. So the effective antibiotics are the aminoglycoside tetracyclines and the macrolides, which are having this modified targeted size. So altered cell wall precursors target glycopeptides, vancomycins, are mainly are the precursors, and large glycopeptide molecules prevent the incorporation of precursors into the cell wall. So these are the various complex mechanisms which you can see, which is the alteration of the rings, alteration of the DNA size or the ribosomal chains, which are leading cause for this antibiotic resistance. So the one of the next one is the bypass inhibition. I don't think you need to know about this because sulbactum doesn't have any role in the bypass mechanism. So these are the target sites you can see that are currently right now. In the left, you can see which was the bypass mechanism of the protein synthesis of the various tetracyclines and other streptomycin organism. And the right, you can see the other organisms currently, macrolides and all. So there are many clinical terminologies. You can see that VRE, GISA, VISA. So what are the ESBL? Okay, and penicillin resistant pneumonia, streptococcus pneumonia. All these terminologies for your reference. Earlier, the antibiotic resistance was low. Now it is at its peak with giving multiple therapies. We are having this kind of resistance right now. So the factors promoting drug resistance is exposure to suboptimal level of antimicrobials, exposure to microbes carrying resistance gene, inappropriate drug use, lack of quality controls, which I mainly focus on the quality of product should not degrade just in terms of price. I know in the corporate sector, we have to keep a good, healthy relationship with the corporates so that we have to afford a better competitive price. But price should not be the main thing. The quality of the product is as much essential because these antibiotics are life-saving molecules and needs to be given appropriately so that the patient, those who require this at the life-threatening infections, are able to survive and get the infection over. Use of antibiotics in food, poverty, war, everything is contributing to the factors. So the whatever I've told, this is summarized in one way, like antibiotics mechanism and resistance, how this reference is having. You can take these details later on and can use it for your references. So what is this crab? The main topic, this carbapenem resistance Acinetobacter, is a significant infections in the healthcare setting. Those who are here, my fellow colleagues are all are knowing this carbapenem resistance Acinetobacter. We have seen resistance of Acinetobacter to meropenem, artapenem, imipenem, any of the penems you name it, we are having resistance to it. We are having 40% resistance over here, at least in all Asia, so that we are having severe infections. Mainly the CRE and the scrab is the main cause for deaths in the ICUs. The mortality gets high. So how to treat this crab? This crab is literally a crab that bites you in your face. Clinicians are worried about this. Even IDSA has developed multiple strategies how to get control of this. So usually what we treat with is with either if we are having a carbapenem resistance Acinetobacter, we can go for a likely a ceftazidime-avibactam along with an aztreonam. But ceftazidime-avibactam is ineffective in these matters as alongside aztreonam. And next options are the polymyxins or colistins. So colistin is somewhat sensitive, but using a monotherapy for crab is again a complication. We have to do monitoring of the drug because it is having some renal toxicity and all. So how to deal? The management of crab infections is difficult for several reasons. Firstly, it is most commonly recovered from respiratory specimens and wounds. Therefore, it is not always clear if an isolate is colonizing or it is attributed for the underlying cause, whether it is due to sepsis or not, or whether it's a colonizer. We are having a hell lot of discussion on this. But usually, if the patient is having clinical symptoms such as the CRP is way beyond the limits, the procal is also high, patient is having clinical signs and symptoms such as fever, and the patient is on life support or having respiratory distress, chest x-rays showing something, or urine culture, anything of the factors you have to be correlated on this because this infection is very much serious right now. So another thing, the factor is we are having very much limited resource of antibiotics that can be used for this crab. So second one, what is the complication? This resistance is more, with other antibiotics as well, but there are other carbapenems such as the OXA24, the OXA group, the OXA23. This carbapenems adds a cherry on the cake, which makes it more difficult for treating this. So if an Acinetobacter comes and alongside this OXA is available, then it is much more difficult because we don't have therapeutic options and drugs in the antibiotics which we can treat, or we don't have any future antibiotics in the pipeline that are promising to be working against this OXA group and other NDM or VIM groups. So what does IDSA says? How to give the dosing of antibiotics to Acinetobacter infections in adult patient with a normal renal function. So the earlier choice was ceftazidime or cefepime or piperacillin tazobactam, ampicillin sulbactam on the other hand, which was given in a 3 gram intravenous for every 6 hours, or mild carbapenem resistance to moderate carbapenem resistance, leading up to 9 gram intravenously. So imipenem cilastatin was also a choice, but from my experience, I haven't seen that much effectiveness of this drug. Ciprofloxacin and levofloxacins were also used, but we haven't seen any benefit on CRAB on this. Usually, all the molecules, including meropenem, are inactive for carbapenem resistance Acinetobacter, but for a general Acinetobacter infection, yes, we can have these choices as an option. So the second line agents directly comes up to colistin, polymyxin B, minocycline, doxycycline, TG-cycline, and cefiderocol. Cefiderocol is now in the last phase of its trial and still not available in India, but it is available in the US. It is having a better response to this MDR Acineto, but unfortunately, we don't have any promising brands that are bringing cefiderocol as of yet. We don't have the information. So we are having colistin and the polymyxins and the tetracycline groups. So usually we have to give multi-dose therapy, which is like a combination therapy other than a monotherapy. Many of you may debate on that why not just colistin if colistin is sensitive, but colistin, polymyxin B should not be used single-handedly for this. So other typical agents like gentamicin, tobramycin, amikacins were also used in the treatment, but are not having that much effectiveness on this. And cefiderocol and colistin are also having some kind of limitation. But usually the colistin and the polymyxin B needs to have a loading dose. As you can see, there are multiple strengths available. If the patient is having a normal creatinine clearance, then the loading dose should be double the amount. Supposedly 4.5 million twice daily is the normal dose. We have to give a loading dose of 9 million units, and for polymyxin B, it will be 15 lakh units stat, then followed by 7.5 lakhs BD. Alongside colistin won't or polymyxin B won't be having that much penetration in the lungs. If the patient is having pneumonia and an acinoto is found, so colistin doesn't reach to the lung tissues that well. So another route of giving is through the nebulization. We can give a nebulizer colistin as well. Minocycline or TG-cycline is the additional molecule that we use alongside with the polymyxins to give it the extra positive gram-positive coverage for extreme or multi-drug resistance uh, uh, carbapenem resistance organism. But now we are seeing that minocycline is also resistant to this Acinetobacter baumanii nowadays. So ampicillin, sulbactam, meropenem, barobactam, these are used nowadays, but polymyxin B, colistin, TG-cycline, and minocycline are the choice of drugs right now currently. And you can see as per the graph, this is taken from the IDSA guideline, that what they are suggesting that ampicillin, sulbactam, 9 grams for every 8 hourly interval for a period of 4 hours infusion should be given for carbapenem resistance Acinetobacter. So this is the option they are suggesting. But if we calculate the dose of sulbactam required, so we are now having this combination therapy, which is having a systematic review. So how much sulbactam to be given to a normal patient if the patient is having normal creatinine clearance? The usual recommendation is 9 to 12 grams per day in 3 divided doses. So it will be 2 gram IV QDS or 3 gram IV TDS to QDS. This is the option we are having alongside either a colistin or a polymyxin B and a TG-cycline or minocycline. So this is how we are approaching the carbapenem resistance Acinetobacter baumanii, and we are having a better results and outcome on this. So this is what we are looking into. So carbapenem resistance Acinetobacter baumanii needs advantage of this sulbactam. So any of the doctors have asked why we need sulbactam, just to have this added on effect, because not just the beta lactam is